Good afternoon, everyone. You are all welcome to this GILEAD Symposium on Advanced HIV disease. And with me here today, I have two distinguished researchers, Professor Meya and Professor Rita, and they'll be speaking to us about this topic. They are the most qualified people to talk about this topic, given their work that they're involved with and their experience. But before they come on stage, I would like to introduce, talk about why we are interested in advanced HIV disease at this very time. So we all appreciate that the number of HIV infections, new infections, have markedly gone down since the introduction of antiretroviral therapy, especially in the low and middle income countries. However, we are still having a high proportion of individuals living with HIV presenting with advanced HIV disease at the time of initiating ART. And this is more noted in the developing countries. So if you look to your right, you're going to see that although we have a marked some significant decline in the number of people with advanced HIV disease, we are still having an unacceptably high proportion of people who are having AIDS-related illnesses and deaths. And this is more so among men this time compared to the women. And UNAIDS puts the number of deaths from AIDS-related illnesses in 2020 at 680,000, which is quite high, though it's a reduction, a significant reduction from what we saw at the peak in 2004 and what we had earlier on in 2010. And for us to be able to meet the global targets of bringing AIDS close to an end and not considering it a public health threat anymore, a lot of effort has to be focused in this area of managing advanced HIV disease and preventing people to getting to this level. So we need to focus efforts on reducing advanced HIV disease cases and deaths by about 90%, which would be a very steep decline. So based on one's risk of mortality from advanced HIV disease, WHO came up with a definition of who is at risk of getting advanced HIV disease and death. And these are all individuals, adults, adolescents, children above 5 years of age, who have a CD4 cell count below 200, but also individuals who have a stage 3 or 4 event. And this includes both those who are naive to treatment, but also those who are coming back to care following interruption. And based on the risk of mortality for children below 5 years, every child with, living with HIV is considered to have advanced HIV disease. So with so much that have been done worldwide, expanded access to ART, test and treat, and of recent transitioning to dolutegravir-based ART, are we making progress? What do we need to do to move forward? So as earlier on mentioned, we have at least a third of people who are presenting for the first time to start ART having advanced HIV disease. Sorry, and these individuals are at high risk, especially following initiation of ART in the first 6 months. And notably, the major causes of death have been tuberculosis, severe bacterial infections, but also cryptococcal meningitis. For individuals, WHO has come up with recommendations for diagnosing, treating, and prophylaxis against getting HIV. But again, for the special group of people with advanced HIV disease, WHO has come up with an intervention, a package of interventions to manage these individuals. And this includes screening, treatment, prophylaxis, rapid initiation of ART, as well as supporting these individuals to adhere to their medications and be retained in care. So we have the first speaker as Professor Rita Oladele, who is going to speak to the topic of emerging so her topic is going to be advanced HIV disease, emerging or neglected opportunistic infections hiding in plain sight. Professor Rita is an associate professor at the College of Medicine, University of Lagos. She's a member of the Nigerian National Task Team on Advanced HIV Disease, and she has been instrumental in mapping the epidemiology of opportunistic fungal infections in advanced HIV disease progression in Nigeria. Dr. Rita is a co-author of 3 international guidelines, and she's also a fellow of the European Conference of Medical Mycology. Dr. Oladele is also the president of Medical Mycology Society of Nigeria, and she co-chairs the Pan-African Mycology Working Group. You're welcome, Professor Rita.
So in Nigeria, we'll say I stand on existing protocol, and I want to thank the organizers for the opportunity to talk about something I'm pretty passionate about. That's opportunistic infections amongst the advanced HIV disease population. So I'm going to be sharing my experience from Nigeria. So this is my disclaimer. So we all know this. We do know that the numbers are markedly, we do know that the numbers assessing ART has increased significantly, and that the target was for deaths to also fall significantly, but we seem to be short of where the death should be at. And the question is why? And so WHO recent guidelines, the 2019 guidelines, showed that one of the reasons is opportunistic infections in the advanced HIV disease population as what has prevented us achieving those reductions, significant reductions in death. And the challenge with that is that in most resource-limited settings, we don't have the skill set, the capacity to make diagnosis of opportunistic fungal infections. When you look in Africa, you look through our labs, most of the labs, we will look at superficial infections, but once it goes invasive, we really don't have those skill sets. So there's that lack of index of suspicion on the part of the clinician, and that becomes an issue because if the clinician does not ask for the appropriate tests, the lab cannot provide the appropriate diagnosis, and the clinician also will not be able to present the appropriate sample. So we have this little vicious circle going around in which we end up misdiagnosing patients. So we end up looking like this. We pretend the problem doesn't exist, like this ostrich with his head buried in the sand. So as long as we don't see it, we believe it doesn't exist, but patients are dying. So Nigeria has the 4th highest HIV burden globally and 3rd highest in Africa. We have an HIV prevalence rate of 1.3, 1.7 million between the ages of 15 to 45. We've been able to achieve ART coverage of 88%. However, we have about 42% of our patients that are newly diagnosed coming in as advanced HIV disease population. And so AIDS-related deaths seem to have plateaued at 49,000. So this is just showing you where we are. And you can see here that we have significant ART coverage, and you expect the numbers, the deaths to come down. But when you look here, you see that we seem to have plateaued with a slight rise even here. And the question is why? So we do believe that There are a number of reasons why. It could be due to delayed HIV diagnosis, and you know what that entails. It means patients will come in late to care, they don't access care early enough. And then some patients abandon care, so they get lost to follow up, and then it could be due to treatment failure, non-adherence, drug resistance. And then of course, critically, even when these patients are diagnosed, we have poor availability and accessibility of the diagnostics and the therapeutic modalities that are needed to save these lives. So this is a summary of Nigerian package of care. We adopted the WHO 2017 guidelines for the advanced HIV disease population, but we also included in our guidelines pneumocystis pneumonia, histoplasmosis, toxoplasmosis, and severe bacterial infections. So one of the critical things is that we have, if you go back to the table I showed, the graph I showed earlier, you can see here that we have this population of the AIDS-related deaths. So TB. Now, one of the challenges, TB accounts for 35%. So one of the challenges is that there are a number of other disease conditions that will mimic TB. So one of those that closely mimic TB is histoplasmosis. Presents practically the same way: fever, weight loss, cough of more than 2 months duration. Even extrapulmonary, it has the same prognosis, the same appearance. So it is critical that we have the right diagnostics available so that we could save lives. And then we wrote this report recently where we reported 9 cases of histoplasmosis patients that were misdiagnosed as TB and were being managed as TB. Eventually, 4 of them died. 1 was lost to follow-up, and 2 accessed care very late. So as a clinician, if you see this picture, what will you think of? What comes to mind? This is the chest X-ray of this picture. Can we be sincere? The first thing that will come to the mind of a clinician is TB. But this is not TB. This patient has histoplasmosis. And then how do we make the diagnosis of histoplasmosis? The greatest challenge is that the gold standard for diagnosis is culture. Most facilities in Nigeria lack the facilities to make it because we lack the level 3 biosafety. Okay, microscopy is not so sensitive, it's just about 40% sensitive. Histology needs an invasive procedure, and it also needs skill set, the same thing with microscopy. So recently, WHO adopted into the essential diagnostic list the histoplasma urinary antigen tests. But how many countries in Africa have it on a routine basis? I think apart from South Africa, everywhere else is none. So does that mean there's no histoplasmosis in Africa? In 2017, we reported that there were 470 cases, case report of histoplasmosis. Only 3 studies in the whole of the continent. And of these, 38% of these cases were in the advanced HIV disease population. But all of them were reported in the advanced HIV disease population from outside Nigeria. We had Nigeria having the second highest number of cases, 147. Of the 147, only 4 were in advanced HIV disease population, and all of them were diagnosed outside Nigeria. They were diagnosed in the Western world. So this is the map of the distribution of histoplasmosis. So you have predominantly capsulatum in Southern Africa, and when you get to Central Africa, you start looking, you see Du Bois, what we call the African histoplasmosis. So I wondered if in Nigeria, Histoplasma took a look at Nigerians and felt sorry and said, your problems are so numerous, let's not add a little more, and decide to take a stroll when they saw HIV coming. because we had no cases of histoplasmosis, despite having the second highest number of cases. So we went ahead and did a skin sensitivity testing, just like your mantle test, to prove that histoplasmosis took a stroll out of Nigeria. Unfortunately, we had 4.4% prevalence across the population. We did not restrict it to advanced HIV disease population. So is histoplasmosis a neglected or an emerging infection? We concluded that it's a neglected infection. And it's neglected because clinicians do not have that index of suspicion. So we went ahead to do a surveillance in the advanced HIV disease population in Nigeria. We came up with a prevalence rate of 7%. These were patients that were being managed or suspected of having TB. They actually had histoplasmosis, with about 2% of them having co-infection of both TB and histoplasmosis. But you can guess what will happen. If these patients are managed as TB, they will die, not because they had treatment failure TB, but because someone did not make the right diagnosis. So it's easy for us to say, let's start looking for histoplasmosis, but we thought the most critical thing was to build capacity. So we got some funding to do training across 10 sites in Nigeria to build the capacity to make the diagnosis and to know how right to treat. And this was the impact of the training. By the time we had done the training, before training, you could see we asked some pertinent questions, a pre and post test, to assess the impact of the training. And I think we're successful. We're able to tell them the right samples to collect, that you could actually use urine of a patient, non-invasive, and the right treatment to be given to these patients. So I come back to this question. Is histoplasmosis neglected or an emerging infection? Is it an elephant that is hiding in plain sight and we're just refusing to see it? As an African country, how many of your facilities make a diagnosis of histoplasmosis in the advanced HIV disease population? These are my acknowledgements. Thank you.
Thank you so much, Professor Rita, for that stimulating discussion. We're going to come to the questions in the Q&A session. And our next speaker is Professor David Meya. David is an associate professor in the School of Medicine at the College of Health Sciences, Makerere University here in Uganda. And he holds an appointment as an adjunct professor of medicine at the University of Minnesota. And over the last 15 years, he's been involved in the clinical research of HIV-related central nervous system infections and complications. Professor Meya has led several randomized clinical trials in Uganda in collaboration with colleagues from University of Minnesota, as well as epidemiological and translational research studies. And in the recent years, he has chaired the Advanced HIV TB Technical Working Group at the Ministry of Health, Uganda, and continues to be involved in the advocacy to improve clinical care and outcomes in persons living with HIV who have advanced HIV disease. He's going to talk to us about refocusing on what really matters. Thank you. You're welcome.
Thank you, Flavia, for that kind introduction. And I'd like to thank the organizers for inviting me to give a talk at this symposium. Now, the topic of my talk does not take away from the incredible talks on COVID that I know at this conference. So this is just one of those things I think that we need to think about. So that's my disclaimer slide. And we all know that it's coming to about 4 decades now, and the HIV pandemic, if you want. And I wanted us to just focus on the 4th row. So there've been almost 80 million documented HIV infected people. Clearly, the numbers are way more than that. There are people who just don't get tested at all. And the number of deaths since the epidemic started has, it's coming to almost 40 million. in 2020, and I think Flavia highlighted this already, there were about 1.5 million cases. Not sure what it's not. Okay, I should probably just go back one slide. Sorry about that. And speaking of East, Central, and Southern Africa, especially, the last 2 decades, the news hasn't all been green. We certainly see that there's been a reduction in the number of new infections by almost 40%. And there's also been a reduction in the number of people who've been dying, as Flavia had highlighted. And just comparing this to the global numbers as well, it's clear that the numbers are, the proportions are fairly similar. I think the difference here is that there's the targets, the 2025 targets, which will hopefully have an estimated less than 500,000 deaths and new infections by 2025. And so just coming back to advanced HIV disease, which Flavia ably defined, we know that the proportion globally lies between 30 and 40%. However, Africa still has carries a substantial burden of this AHD patients, almost up to 70% in some places. And we know that most of these patients are presenting after disengaging from care. Despite access to almost 3/4 of people who have HIV now, we still have, there were about 700,000 deaths in the 12 months leading up to June 2021. So let HIV diagnosis, suboptimal treatment of opportunistic infections clearly remain important contributors to AHD incidence. But we also know that poor resource allocation, shaky commitments to implementing AHD interventions, and limited healthcare worker knowledge all play a role in AHD mortality. And the bigger one that I will be focusing on is really inpatient care. Roger Singham and others have come up with this figure that really shows the burden of advanced HIV disease in sub-Saharan. If you look at that figure, the majority of countries that have this problem is really countries in sub-Saharan Africa. Notwithstanding, the COVID pandemic has obviously had an impact on advanced HIV disease. And this data, which is from the municipal clinics in Kampala, here in Uganda, showing that the number of individuals who had who came in or presented between pre-COVID, I think it was about 16% who were presenting with advanced disease. Then during the lockdowns, which I've sort of highlighted there in those 2 red circles, there's that dip in especially the first lockdown, and only 9% of people were presenting with advanced HIV disease. And so overall, there was about a 33% reduction in the monthly average number of people presenting with HIV who had advanced disease. And that translates to about 62% reduction in the monthly average. And so clearly, the number of patients that we're going to be seeing coming to the hospitals because of advanced HIV disease are in some ways going to be because of what happened during the COVID pandemic. I think there's some deficiencies in inpatient care, and I think this is what is really driving mortality. It's important that we think about mortality, sort of being at the apex, if you want. HIV program goals that we've all had, over the last 3-4 decades have mostly focused on ambulatory care. But we also have to remember that there is hospital care as well, which we need to pay attention to. And until we have those 3 sort of in alignment, we're going to continue to have mortality from advanced HIV disease. I just highlight results from one small study that was done in a hospital here, a referral hospital, that of individuals who had been admitted, about 65% had a CD4 less than 200. Only half of those started ART while they were in hospital, with about a third of them having same-day start. The 10% loss to follow-up is obviously significant. Within 30 days, and almost 20% of those patients had died within 30 days. And clearly some of this is resulting from what transpired during their hospitalization. I think for me, I'm putting up here what I think is a paradigm for advanced HIV disease. I think right up there, you have programs sort of struggling to prevent HIV. I agree that it's important that they also include AHD identification. And there's a pillar of the incidence of AHD, which we all know will be supported well or decreased if you have patients starting ART well, you have your TB preventive therapy, you have your differentiated service models working well as they should be, and if patients who should be on cotrimoxazole are taking the drug. On the other hand, of course, you do have the pillar of mortality due to advanced HIV disease. And as you know, as has been highlighted, this will happen because of different opportunistic infections, perhaps and cancers. If you think about stage 3 and stage 4 diseases, pneumocystis, Saccharomyces, cryptococcal disease, tuberculosis, severe bacterial infections, histoplasmosis, as Rita has pointed out, as well as aspergillosis. Now, this data from the Uganda Ministry of Health covering the period of the year 2020, again, looking at the cascade of patients who were, those who were naive to treatment, having, almost 120,000, and of those, only 45% got a CD4 count done. And of those who had a CD4 count done, about 25%, a quarter of those had advanced HIV disease by definition. Among those patients, 70% had a CRAG test done, and the CRAG positivity rate was 11%, and about 86% of those started fluconazole, the intervention. And then when we look at the TB, 60% of those with CD4 less than 200 got a TB LAM test, with almost 20% having a positive test, and about 87% of those starting TB treatment. And when we quickly look at the proportion who were non-suppressed, those figures are essentially similar. Now the trends, sorry, I don't know what happened to this, my apologies. The trends of mortality are clearly problematic. You have almost 2,000 to 3,000 patients dying every quarter. And this data was really put together from a call for mortality that was sent out to facilities. Clearly, there is a huge problem of mortality due to AHD. We need to come back to research, and there's a few things that I will highlight here on what we've learned. There clearly remains a high burden of cryptococcal meningitis, and this is from a study done in northern Uganda, which is part of rural Uganda, among patients who had started antiretroviral therapy. So they were ART experienced, but we still found a high incidence of cryptococcal meningitis. There's also the question of gender differentiation as far as mortality and outcomes are concerned. And in this paper that Pastic and others published, there was about a 30% higher mortality among women who had cryptococcal meningitis. There's a PhD student who's looking at the question of whether that was an immune-related cause as well. And looking at the combination of patients who are co-infected with TB and cryptococcal disease, again, studies here in Uganda have shown a higher hazard of death for those who are co-infected. And finally, a study that is not yet published that looked at the outcomes among patients who were referred to hospital at the time that they had had a CRAG screening test, or at the time they were admitted with cryptococcal meningitis. It was very clear that those who had been CRAG screened and then referred to hospital had much better outcomes. I think for me, the two important studies this year that have been published, especially as far as AHD is concerned, have been the Ambition trial, which looked at single dose ambisome together, of course, with the background of flucytosine and fluconazole, and compared that to the current standard of care, showing that that regimen was non-inferior. I think the important thing about this study is that it's hopefully going to be implemented and that there will be better access for these regimens. The cost, and this is data that's just been submitted for application, I think at least for Uganda, was about $140 per life year saved. The other important one, I think, was the 4-month rifapentine regimen with or without moxifloxacin that was also published this year. And shortening the regimen for TB treatment will hopefully then improve adherence. And if it's a cheaper regimen, the programs will obviously be spending much less as well. There have been strategies to end cryptococcal disease and TB, and we all know about the Invest to End TB strategy, as well as the more recent one, the End Cryptococcal Meningitis Deaths by 2030 strategy as well. A couple of us published an opinion piece recently, I think it was at the beginning of this year. And if we've been talking about focusing on targets for a number of new infections and the deaths, I think we should be talking about targets for advanced HIV disease as well. And hopefully this is something that we will continue to advocate for with UNAIDS and other global partners to ensure that we do establish and meet the targets for advanced HIV disease. The figure that I highlight here is really looking at what the ideal target for CD4 testing, for CRAG and TB-LAM testing, as well as initiating fluconazole and TB treatment should be. What should we refocus on? I think there's a couple of things, and some of these have already been highlighted. Increasing access to testing, CD4 testing platforms, the most convenient ones. I think right now there's the Visitect, which is becoming increasingly available. Challenging AIDS care programs to have set targets. So for TB-LAM testing, so maybe 100,000 tests in 100 days. TPT uptake, healthcare worker access to knowledge. And I know that CHI is working with the Infectious Diseases Institute to develop a mobile AHD app. And then, of course, advocacy and access to shorter and more optimal treatment regimens. And Rita already talked about this histoplasmosis and aspergillus screening. I think behavioral science cannot be ignored in designing interventions that we need to decrease the incidence and mortality of AHD. And those of you who've read Thaler and Sunstein's book, Nudge, which should be read by every policy caremaker, I think all of us are choice architects, and we should be designing specific interventions that nudge people living with HIV to limit AHD incidence. Mortality data being shared with frontline healthcare workers, I think, is important. The public messaging, we did this a lot when we were talking about prevention of HIV. We probably need to do the same thing for AHD as well. Documenting mortality better, optimal task sharing, as well as providing specific funding for AHD care. But more importantly, and I apologize for bringing Elon Musk into this, but I thought I would share this tweet. I tweeted this when there was a conversation around hospital care in Uganda. I think fixing our hospitals is going to require our mindset as Ugandans to change. I'm not going to speak for the rest of Africa, but if you're from other countries in Africa, think about this. I think it's key that at our core, we begin to value lives and all of our lives. I think that's what's going to help that fix to happen. It's very random things that you see, people not stopping at zebra crossings for pedestrians. It's really because you don't value the pedestrian's life. Stealing drugs from government hospitals because you don't value the lives of the people that are going to be in that hospital. Anyway, this is a debate we can have, but thank you very much.
Thank you so much, Professors Meya and Rita, We are going to open the floor to questions. We are doing very well regarding time. So thank you so much for being brief and also for highlighting important gaps in the advanced HIV care package, as well as showing us that we need to look beyond from Dr. Rita's presentation. So do we have questions? Oh, there seem to be several. With number one, give number two.
Okay.
Okay, we can start with him.
So yeah, my name is Kwesi Tope, and from the University of Ghana. Good presentation and congratulations. I think advanced HIV disease has been quite challenging because if you look at a lot of the facilities, they don't routinely do CD4. And I agree with most of the strategy that has been outlined in terms of improving outcomes for advanced HIV disease. But one, for me, the most important point actually didn't come out, because advanced HIV disease is a failure of the first 95. Because if we diagnose them early, we reach out, then there will be no advanced HIV disease. So the strategies that we are seeing, that bit was missing. I really don't know why.
And the question goes to Dr. Meya, Professor Meya. So let's have about 3 questions, have responses, and then we continue. Yes, please.
Thank you. My name is Edith Magak from the National AIDS Map in the UK. I have a question to Dr. Meya. So there was a recent study that was released by the Open Forum Infections, and the study was highly conducted in Nigeria, South Africa, and Uganda. So the study found that treatment failure and delays in switching, patients to second-line ART. Actually, there was an average wait of 17 months before patients were switched to second-line treatment. How high do you think this risk is of contributing to advanced HIV disease vis-a-vis, TB and other?
One more question. 2 questions for Professor Meya. One more question. Yes, please.
I'm called Patience Atuhere from the MU-JHU Research Collaboration here in Kampala. I have 2 questions for Dr. Rita. One, you presented that you have up to 42% of your patients coming in with advanced HIV disease. I'm just curious, what are the drivers for the particular presentation? And then what's the burden of treatment failure in your setting? And then also, lastly, the HIV-associated cancers, Kaposis and the lymphomas, cervical cancer, what's their place in this, in AHD? Thank you.
Thank you, Patience. Can we have Dr. Meya go first?
Okay. Thank you. 2 important questions. I think the paradigm that I showed had, sort of right at the top, HIV prevention. And I think I totally agree with you that failure of HIV programs will partly manifest as, as in the incidence of AHD. I think it's key that country programs, so I guess there's 2 things. There's individual behavior. And one of the reasons I talked about social behavioral science being integrated in some of these programs is because I suppose HIV is a very individual disease, if you want, a social individual disease. If you do choose not to take your drugs, nobody can do anything about that. Sometimes that's what we're seeing those are the patients we're seeing presenting to hospital. But we're also seeing those patients, obviously, who were not able to access HIV testing services because they were not brought close to them. There were no mechanisms to ensure that it was easy for them to get tested and easy for them to get linked to care. So I totally agree that that's an area that needs to be handled by country programs. The second question I think feeds into this the failure of programs. So delayed switching is clearly one of those, and I totally agree, I did not highlight that, but I think it is one of those things that is also influencing AHD incidents. I think there's a tendency for, for example, if a country program is going to depend on centralized testing for viral loads, that might take up to, in some places, 3-4 months before results come back, before decisions are made and that sort of thing. And so personally, I would advocate for point of care viral load testing, because I think then you're empowering the healthcare practitioner to make certain decisions right there and then. There's obviously issues around what is also available in terms of treatment regimens, which is, I think sometimes it's more of a cost issue. But I totally agree that that's something that we need to address as country programs.
Yeah, thank you, Dr. Meya. Professor Rita.
Okay, so 42%, that's average across countries. Some sites have as high as 50 something even. And some of the drivers that we have identified is where, I believe Nigerians are like the Africans. So most of our patients, some of these patients are patients that have sought help, probably went into denial, they've gone to church, they've gone to the herbalist, they've done all, and then they come back. Our patients tend to be very fluid. So if you don't have a good news here, you try somewhere else. So we have lots of defaulters, and then the program, in-country program, has actively gone back into the community to start testing and counseling. So maybe that's why we have more coming in, and a lot of them probably are returning to care, but they won't say so because they just go to a different facility. But also, we also need to look closely and see something else driving it underground, and those are data that we are presently collecting and we've not concluded on. The burden of treatment failure, I think that's also encapsulated in what I've just talked about. My people tend to be pretty religious, and it's not my portion. And so they seek help, and they seek help. You can't, like David said, you can't force compliance. You can only cancel again and again. So all those contribute. And then, but the challenge there is also that with these treatment failures, opportunistic infections become a major challenge with them. So it's critical that they change a regimen fast enough. And then you talked about comorbidities of Kaposi and cancers. If you look at the guidelines, the advanced HIV disease guidelines, it did make emphasis on vaccination for HPV. And then Kaposi, our rates seem to have decreased significantly in country. I will know the driver for that.
Yeah, thank you so much. A related question, Dr. Rita, as people go to the religious leaders and other places, so how can we involve the community to make sure that they work with us to have these people supported?
Yes, I do think that being ostriches is not going to help us. It has to take everybody putting hands in. In my country, in some churches, if you don't have an HIV test result, they won't wed you. Okay, and I think we should not just do it with the churches. If you don't, I mean, we need to carry everybody along, the imams, the herbalists, to drive this message. It will be critical. And so that more people get tested and they test early and then get put into care early enough.
Yeah. Okay, thank you so much. More questions? Yes. And then thereafter, someone here.
Thank you so much. This is Dr. Jacqueline Balungi Kanywa with Baylor College of Medicine, Children's Foundation, Uganda. I have two questions. One is for Professor Rita. I was wondering what's the current median age of people living with HIV, dying with advanced HIV disease? Why I'm asking is, do we consider the life expectancy of a community and maybe disaggregate the data? Because I think it's more comforting if someone maybe passed their life expectancy for their country, and they rested than if someone went too soon. So I don't know if the data is ever disaggregated, because I looked and we have almost 47 million people who have died of AIDS since the pandemic started. So I was just having those kind of questions in my mind. And then the question I have for Professor David, Meya, I'm just wondering, could, and it might sound a little bit dumb, but could targeted HIV testing be contributing to late diagnosis? Where I'm asking, I know it yields, we do get a lot more people identified, but we also have scenarios where, for example, I'm a doctor who sees patients and I know what's on ground. Sometimes you meet this person who is newly diagnosed with HIV and they've had a very rough past with their sex partners and they don't even have their contacts, like they really cut them off. They want nothing to do with them. So could it be it's those kind of people who fall through the targeted testing that later show up with advanced HIV disease? Because in the past, I know we used to have mass testing. I know we can't go back there because it proved there wasn't value for money, but could these things be tied to what we might be seeing? Thank you very much.
Yeah, thank you, Jackie. One more question here. Yes, please. Someone there.
Yeah, thank you so much. My name is Happy Betty Paul from the Elizabeth Plazer Pediatric AIDS Foundation. Thank you so much for the presentation. I have two questions. I think one to Dr. Meya. Thanks for the data. I just want to ask if you have made any observations about AHD in children and adolescents, anything you can share with us. I would be happy if you have anything, any picture for Uganda. And then to Dr. Rita, my question is about community engagement in your setting. Given the burden that you have of advanced HIV disease, how much have you done in the community? Is there anything to learn from you as far as community awareness is concerned? Thank you.
Okay, yeah, I love the balance between Professor Rita, Professor Meya. So Professor Rita, can you please go first?
I start?
Yes.
Okay, so I think I'll start with community engagement. So I think I should put a disclaimer here. I keep telling people I am not an HIV clinician. I'm a clinical microbiologist, but I do know that the Ministry of Health and implementing partners in my country are part of those driving this advanced HIV disease program. They are going into the communities, they are meeting community gatekeepers and encouraging counseling for testing and doing very, I would say, very aggressive follow-up, even on tested cases and their contact. So there's a lot of community engagement going on in my country. I'm not directly involved in it. I can't give you the exact statistics, but I do know we come to these meetings and there's a lot of feedback that is very encouraging. And then regarding the current media age, I don't have that data. I don't have that data on me, yeah, but I do know that life expectancy for this population has gone as low as 47.
Professor Meya, briefly.
Yeah. Thank you. The first question on HIV testing gaps, I think that's what you were referring to. You know, are we testing the right people, the right groups of people? I think the onus is really on the HIV testing program to, I think to figure out how to go out to communities. And I agree that mass testing is not being done anymore. That's not the model that we're working with. But there are clinics that are seeing individuals, let's say individuals, that are not necessarily falling within what we call the high-risk groups. And so if you think about facilities where people that are experiencing gender-based violence are coming to for help, that could potentially be, I think, a place where HIV testing is offered as an add-on, because we know that there could be a risk for those individuals having HIV as well. So I think it's thinking about targeting those other the non-traditional facilities, so who are offering support for other people as well. The second question is hard especially for an internal medicine physician, but we certainly know that adolescents and children are really not getting cryptococcal meningitis as much as adults. So I think that's one area that I think there isn't too much of an issue. TB definitely is still an issue among children, and especially considering that the diagnostics are even harder with pediatrics. Dr. Sabrina Chitaka, I don't know whether she'll probably answer that question better than I would. Thank you.
Okay, thank you. So we're going to have, sorry.
I want to talk about pediatrics, and I do agree that pediatrics AHD is one very neglected group. We're pretending it's not existing. Recently, my facility, I went to look at the data. I wanted to look at it and say, do we have a problem here? And of all the children in the program, my center has a 15,000 client base. Of all the children in the program, over 50, I think 57, 58% fell into the category of advanced HIV disease. But nobody's talking about it. Nobody is doing anything. And we are good ostriches. It will catch up with us sooner or later.
Thank you so much. So do we have an M&E system in either Uganda, Nigeria, or any country where we follow up with these patients and document the outcomes?
So I'm not a program person. I really won't have
Dr.
that.
Meya,
But I think
we have an M&E
my program, where is it?
For monitoring advanced HIV disease.
For monitoring advanced HIV. Oh,
adults,
yes, we
children.
Do. Yeah, we do have that. I don't know about children, but for adults, we do have a very robust AHD monitoring team. And that does it because we are part of the United Child Grant, and then it has now been scaled out across the country. So we do have very active monitoring and evaluation going on, but the focus has not been on pediatric group at all.
Okay.
Flavia, considering some people clap from the audience, I think there's a huge gap there that needs to be thought about.
Yeah, so unfortunately, we are coming to the end of our time. Let's just have one question there and here. I would appreciate if one is for Dr. Rita, one for Professor Meya, and then as they answer the questions, you give your parting shots. Yes, number 3 and number 1.
Thank you, Professor Rita. I am Samuel Oladele from Obafemi University, Nigeria. Thank you for your work. Actually, you talk about neglected opportunistic infections. Most of our eyes are waving away from all these neglected opportunistic infection, but you talk about inability of diagnosis centers to be able to discover all these things. And you also talk about your group building up, having some capacity build up, and this has been producing a positive effect. But the question I want to ask is, what is your role in order to make sure that this capacity building is extended to other parts of the country? Now, this is a big problem. And since you've been having a positive contribution towards it, what is your role to extend the effort in order to solve the problem in the country? Thank you very much.
Okay, thank you so much. The last question, number 1 here. Yeah, last question.
Yeah, my name is Sabrina Chitaka. I am a pediatrician. And thank you, Dr. Meya and Dr. Rita. Indeed, children have suffered a lot from advanced HIV disease, and we saw this a lot during the COVID lockdown. But my specific question to you, Professor Meya, is you've recommended that we do CD4 counts. It reminds me of the time we had a great debate on should we do CD4 counts of viral loads? And this was way back in 2014. Are you taking us back there? The reason I ask is there's a lot of immune discordance. You know, patients may be virally suppressed, but still maintain a very low CD4 count and be stable. And unless we look at it at a higher level, we may go away with the wrong message. So I need you to clarify on this.
Okay.
Thank you.
Thank you so much, Dr. Sabrina. So Dr. Rita, Dr. Meya, you respond as you give your last words.
Response and-
As you respond, you give your parting shots because we are coming to the end of the session.
So extension to other parts of the country. I do believe that once we bring out some very good data and put sufficient pressure on implementing partners, we'll get there. Why do I say so? In 2011, cryptococcal antigen tests were brought into Nigeria. They expired in the stores. Despite them having been included in our guidelines, nobody tested. Then we, as a society, got some funding from CDC to do a multi-center crack screening. We presented the data, and I'm a strong believer in capacity building. I don't like other people taking ownership of my problem. I take it on. So we got to do trainings in 14 sites in Nigeria. And with the data, we made advocacy. And those are part of those advocacy led to Nigeria being included in the AHD package of care. And I'm sure you're aware now, from just 28 sites, we've rolled that across country now to 2,000 sites. And we want to do the same thing with histoplasmosis. Science does not lie. When you give them the data and the science, I do believe we'll get to Ife. And I think opportunistic infections occur in Ife, because if you look at the data on histoplasmosis before the advent of HIV/AIDS in Nigeria, we have quite a number of cases that came from Ile-Ife, reported from there. So if you are not seeing it now, doesn't mean that it does not exist. It's just that you're a lovely ostrich and having fun. It will catch up with us. I mean, people are dying unnecessarily. It's a drug that is a disease that is treatable. Well, I get passionate, forgive me. So my parting word is this: these opportunistic infections are not emerging. They've been with us, we're just pretending. So they are neglected diseases, and it's high time we take ownership of our problems and make a way forward for them. Thank you.
Thank you, Professor Rita. Professor Meya,
Okay.
Response to question. And
yeah, thank you, Sabrina, for that question. And so just to clarify, CD4 testing will be for people who are naive to treatment and people who are not virologically suppressed. The reason is you want to identify who has advanced HIV disease. So that's the current definition of advanced HIV disease. It might change in the future, but that's what we're using right now. Those are the two groups of individuals who you should do a CD4 test on. Parting shots, there's incredible momentum, I think, right now around sub-Saharan Africa to drive back the mortality and incidence of advanced HIV disease. And that's why you're all in this room this afternoon. And hopefully we will all partner together, whether that's pharmaceuticals or, and just to really thank Gilead for thinking about this symposium, but other funders as well, to make sure that people do get treated once they have advanced HIV disease. But I think more importantly for us to think about the fact that people who have, if people show up with advanced HIV disease, then there's something going wrong with our country programs, HIV country programs. And so we need to think carefully about that together. Thank you very much.
Okay, thank you so much. Yeah, thank you so much, Dr. Rita and Professor Meya. I believe we have policymakers in the room and program managers at national level, as well as funders and other partners. So as the HIV epidemic matures, we realize that we need to have our health systems quickly evolve to be able to handle cases of advanced HIV disease, but importantly, intensify screening and also involve other categories. We're appreciating that children have been left out in a way, And also we need to expand the screening and testing for histoplasmosis. Nigeria has gone ahead of us, but if we looked for it here, if we looked for histoplasmosis, I'm sure I would find a significant proportion of patients with this disease disguising as tuberculosis. So thank you so much. We can have another round of applause for our presenters. And the last word from our sponsor for the session, GILEAD.
Thank you very much, Dr. Flavia. And what started off as a discussion on advanced HIV disease has opened up how multifactorial this challenge is, from the pediatric issues that have come up, from community issues that have come up, and not just the infections or the hidden or emerging or neglected infections. And I think as a community of policymakers, clinicians, what we will live with today is to go out and have this conversation more and more so that we can change what is happening currently from an advanced HIV disease standpoint. And we as Gilead are keen and happy to stand behind this kind of work and to partner and so that we achieve our ultimate goal, which is to really end this pandemic. Thank you very much and have a great afternoon.